All right, so we will be starting the Endocrinology Step 1 QBANK, and we've already done two videos on this topic before. This will be the third video, and as always, we will be following a series of questions. Those questions will incorporate UWORLD and NBME concepts, and after encountering those questions, we will be doing their explanations and also recording how to tackle these kind of concepts in the real paper. So let's get to it. Right. So, which of the following findings is most specific to this patient's underlying condition when compared to other causes of thyrotoxicosis? A 44-year-old man presents with persistent fatigue, poor sleep, palpitations. He reports an unintentional 9 kg weight loss over the past year, despite a good appetite. He denies tobacco, alcohol, or drug use. Family history is significant for thyroid disease in his mother. Examination reveals a diffusely enlarged thyroid gland, blood pressure of 140 by 80, and a pulse of 108. Lab studies show elevated free thyroxine and suppressed TSH. Thyrotropin receptors antibodies are positive. Which of the following is the most specific to this patient's underlying condition? So I'll give you a minute to think of an answer. This is an example of an easier question. So if you're looking at this question and you think this is difficult, it is not. It is a very easy question because it gives you a lot of hints towards the diagnosis and towards the answer. Let's look at the answer now. So the answer is skin thickening and induration over the shins. So the patient has Graves' disease, which is causing the hypothyroidism and the symptoms that he is facing, such as persistent fatigue, poor sleep, and palpitations. Let me show you. So these are the symptoms that he is facing. He also faces weight loss despite a good appetite. So this is unintentional weight loss. And he has thyroid disease in his mother, so there is some family history. He also has a diffusely enlarged thyroid gland. He has hypertension and also has tachycardia. So this question is essentially filled with clues. So the basic thing that you need to understand is that the most specific finding is pretibial mixed edema. Because all the other findings that were mentioned in this question are findings of thyrotoxicosis. Basically, any condition that leads to an increase in the free thyroxine hormone or the T4 level of blood will give rise to those symptoms, which is known as thyrotoxicosis. But the most specific part of the question that points to Graves' disease specifically is the presence of pretibial mixed edema, which is the skin thickening and induration over the shins. That is the most specific finding. As the question mentions that there are other causes of thyrotoxicosis also. For example, subacute granulomatous thyrotoxicosis, thyroiditis, postpartum thyroiditis, toxic adenoma, multinodular toxic goiter. So there are other causes of thyrotoxicosis, but what is the most specific cause of most specific sign that points towards Graves' disease, which this patient has? Now, how do we know he has Graves' disease? Because they've already told us that he has a thyrotropin receptor antibody, right? So they've already given us this clue. So that is why the pretibial mixed edema is the specific answer. So what the pretibial mixed edema is, it's a condition in which there is a localized skin thickening and induration over the shins that is caused by the fibroblast stimulation and excess glycosaminoglycan deposition. The the other findings are non-specific and they can occur in all thyrotoxic states, such as atrial fibrillation, decreased bone mineral density, and heat intolerance. tremor of the outstretched hands. All of these can occur in other thyrotoxicosis conditions as well. But the myxedema, the skin thickening, it is specific to Graves' disease only. Okay, so you can pause the video and read the explanations as well. But I'm going to move on since it's very easy. So which of the following is the most important underlying factor in the formation of this patient's foot ulcer? He is a 58-year-old man presenting with a non-healing ulcer on the sole of his right foot that appeared a week ago. He does not recall any trauma and has type 2 diabetes for 15 years, and he has been poorly adherent to the treatment. He smokes 1 pack of cigarettes daily for the past 20 years. Temperature is normal. There is hypertension, and the pulse is also normal. On examination, there is a 1 centimeter ulcer beneath the first metatarsal head. Tibial and dorsalis peris pulses are palpable and symmetric. So basically, they're saying what is the most important underlying factor. All of these factors can be present in this patient. But the most specific factor would be sensory impairment. Sensory impairment because they have already mentioned to you that the patient is poorly adherent to the treatment, which means his type 2 diabetes is not adequately controlled. Now, when diabetes is not adequately controlled, what happens is that the patient starts to develop paresthesia and neuropathy in different parts of the body. Basically, the neuropathy starts from the feet and the hands. Glove and stocking neuropathy is a common terminology used to describe diabetic neuropathy. So what has happened is basically the patient has uncontrolled diabetes and he has neuropathy occurring in the feet. And due to neuropathy, he has a loss of proprioception. And due to the loss of proprioception, he now has an ulcer under the first metatarsal head because he cannot adjust the foot along with the pressure of the ground or the pressure of the trauma. So reading the explanation, the patient has a neuropathic ulcer, which is commonly due to the peripheral sensory neuropathy. Chronic hyperglycemia damages small nerve fibers leading to loss of protective sensation, especially on the pressure points like plantar surface. Minor trauma goes unnoticed, resulting in ulceration and poor healing. Normal distal pulses make ischemia less likely. So that gives you a hint that there is no arterial problem related to this. This is purely sensory. Right, so if this was atherosclerotic disease, it could cause ischemic ulcers, which are typically on the tips or toes of lateral malleolus with diminished or absent pulses. But the patient had normal pulses. Bacterial infection could complicate the ulcer but would not be the initiating cause, and it could also lead to cellulitis and osteomyelitis. Irritant dermatitis causes superficial inflammation. It does not cause deep plantar ulcers. It would be right if the lesion was due to repetitive chemical or moisture exposure, but that is not mentioned in the history of the patient. Systemic vasculitis produces multiple painful ulcers with purpura or livido reticularis. It does not produce isolated plantar lesions. It would be correct if systemic inflammatory features were present. Venous insufficiency ulcers occur over the medial malleolus with associated edema and hyperpigmentation, not on the pressure points. Would be right if chronic venous stasis were seen, such as hyperpigmentation or varicose veins or any venous ulcer that would have been visible over the medial malleolus. I saw 50, let's read from the bottom line. Which of the following hormones is most likely elevated in this patient? 50-year-old woman presents because her menstrual periods have not resumed since stopping oral contraceptive pills 3 months ago. She had used them continuously for 17 years. She reports mild vaginal dryness, but no dyspnea. Her BMI is 21. vital signs are normal. Pelvic examination shows normal vaginal mucosa, cervix, uterus, and ovaries. Urine pregnancy test is negative. So, which of the following hormones is most likely elevated in this patient? And the answer is FSH. Because this patient is likely in menopause, which typically occurs around age 50. Ovarian follicle depletion leads to decreased NBME and estrogen production. Loss of negative feedback on the hypothalamic pituitary axis causes the increased FSH and LH levels. Vaginal dryness supports estrogen deficiency. So, they've already mentioned vaginal dryness, they mentioned the age of the woman, they have also mentioned the BMI. Everything looks normal. So, they would try to distract you with the fact that she has been using oral contraceptives for quite some time, but you have to understand that the overarching concept being tested in this question is for menopause and the failure of the ovarian follicles development. Right, so beta HCG would be negative with the urine pregnancy test. It would be elevated in pregnancy. Estradiol is decreased in menopause due to ovarian failure. Progesterone is low because of anovulation and lack of corpus luteum formation. It would be elevated in the luteal phase of the normal menstrual cycle. Prolactin would be normal here because hyperprolactinemia causes amenorrhea due to GnRH suppression, and also causes galactorrhea, visual and headache changes and other symptoms as well, which are not present here. So this supports FSH. Which regimen most closely matches the physiologic insulin patterns? A 55-year-old man presents with 3 months of polyuria per day lethargy and 5 kg weight loss. He's found to have a glucose of 600, normal beta hydroxybutyrate, and HbA1c of 14. After IV fluids and insulin infusion, his glucose and symptoms improves. For discharge, his inpatient insulin infusion is converted to subcutaneous regimen that best produces normal physiologic insulin secretion, which regimen most closely matches physiological insulin patterns. So for that, you need to know that what are the physiological insulin patterns. So what happens is insulin releases after every meal. I will demonstrate. So after every meal, your insulin increases, and your insulin also releases throughout the day to maintain simple, basically a baseline glucose level. So you need to know the physiological insulin pattern. So we discussed that more. Think of an answer. Insulin glargine once daily plus insulin lispro before each meal. Why? Because lispro would cover the insulin release after the meal, and glargine would provide the baseline. Right. So that's what is written here, that the physiological basal bolus regimen uses a long-acting insulin, glargine, to provide a steady background insulin, and a rapid-acting insulin, which is lispro, before meals to cover the prandial glucose excursion. This closely mimics endogenous pancreatic insulin release, which is constant low-level basal secretion and spikes with meals. It's preferred approach for most patients transitioning off IV insulin. So you have to keep in mind the physiological pattern of the insulin to get this answer right. Insulin aspart before each meal, rapid-acting insulin alone lacks a basal component, therefore does not prevent fasting and hyperglycemia between meals or overnight. Would be appropriate only if endogenous basal insulin was sufficient, which is rare in uncontrolled insulin deficient patients. So that is the wrong answer. Insulin determinant twice. Now, insulin determinant is a long-acting basal given twice, provides big background insulin but lacks the prandial coverage. Non-physiologic alone could be used as a basal part of the basal bolus plan but would still require rapid-acting boluses at meals. And insulin glargine once daily, again, only the basal insulin is provided. the primary insulin is not provided, right? And NPH premix with insulin regimen daily, it provides some basal and parenteral coverage, but it's less flexible because NPH has a shorter duration, modern basals, and it's poorly matched. So both of them are short acting, right? Sort of. So they won't really have that maximum effect. Okay, so which of the following enzymes has increased activity contributing to her current metabolic state? 72-year-old woman brought to the ED after being found in her bathroom floor where she had been lying for 2 days. She reports falling and being unable to get up to call for help. During this time, she had no food or water intake. On examination, she appears dehydrated and has right hip tenderness. Her radiograph shows a femoral neck fracture. So the lab test reveals glucose level of 72 and positive urine ketones. Which of the following enzymes has increased activity, contributing to her current metabolic state? This is a biochemistry kind of a question. Okay. The answer is hormone sensitive lipase because this woman has experienced starvation and stress. So falling insulin and rising catecholamines activate hormone sensitive lipase in the adipose tissue, which releases the fatty acids and glycerol into the blood by hydrolyzing the stored triglycerides. That fatty acids are in turn transported for the liver for beta oxidation and ketone body protection, giving positive urine ketones. So that is the right concept. Glycogen phosphorylase is used in glycogen breakdown in liver and muscle. It rises only in fasting but declines afterwards, and would be correct if she had fasting for a shorter duration. But because she is fasting for a longer duration, then we'd go for the lipid. Right. Lipoprotein lipase degrades triglycerides in circulating chylomicrons and VLDL, allowing fatty acid uptake by tissues. It is insulin dependent and decreased during fasting, not increased. Would be right in the fat state, aiding fat storage. Because it degrades the triglycerides, it can be used during the fed state, not during the fasting state, because it is insulin dependent, right? So because we'd have less insulin in the fasting state, this hormone would not work. Mitochondrial HMG-CoA synthase, it basically is involved in ketogenesis and only activates after fatty acids are supplied by the HSL. Although both are active, HSL is primarily responsible for the mobilization of the fatty acids, not HMG-CoA synthase. It only synthesizes the ketones. It does not mobilize the fatty acids. So this would be a better answer. Don't get confused between the two. This would be the better answer, HSL. Although both can be active at the same time. And phosphofructokinase 1, rate limiting enzyme of glycolysis, inhibited during fasting by low insulin and ATP citrate, would be active in a fed high glucose state, not in starving state, because if it is working, it is only inhibited by high ATP and citrate, right? So it would be inhibited by high ATP and citrate. So it would only work in fed state, not starvation state. Right? So I hope that was clear. It is a rate limiting enzyme, glycolysis. Glycolysis will only occur if you have sufficient glucose molecules available, which should occur in the fat state only. So you have to remember that it depends on the glucose molecules.